Welcome back to Grand Rounds. As always, please remember to fill out the attendance evaluations and give us ideas in regards to topics that you'd like to hear in the future or speakers you'd like to hear in the future. Also, please remember to fill out the attendance record at the back of the auditorium. Today, it's my pleasure to actually reintroduce Dr. Jarrod Tucker. Dr. Tucker attended to his undergraduate training here at Iowa State University, where he stayed to receive his Ph.D. in counseling psychology. Currently, he is a clinical psychologist at the Cancer Resource Center and also assistant professor at Des Moines University. He is here to discuss a hot topic in the news recently, that being provider burnout, and the title of his discussion today is Provider Distress, Responding to Our Colleagues, and please join me in welcoming Dr. Jarrod Tucker.
Thanks, Dr. Hardy. Can everybody hear me okay? Broadcasting? All right. So, yeah, absolutely, burnout is a buzzword. You know, it's in the Lancet, it's in the journal, the American Medical Association. It's everywhere. There's AMA modules on burnout. It's a huge topic right now, and my hope is that this can be more than just sort of a buzzword today, that we can dig a little bit deeply into the realities of burnout, and sort of the opposite of burnout. You know, burnout is a workplace-related phenomenon. The opposite of burnout is engagement. So my hope today is to engage you a little bit, that we can actually have a discussion about these topics. We'll do a little survey. We have the Turning Point software, so we're going to try and fill out some questionnaires related to burnout. It's anonymous, don't worry. And we'll just talk about this as it's related to our own lives. This is a huge area. We're going to go pretty much the whole gamut. We're going to start with burnout. What is burnout? What does it look like? What predicts burnout? How does it impact us? Why is it important to talk about? Why is it on the rise? And we'll end with, provider distress all the way to physician suicide and healthcare provider suicide, and why is that important for us to be talking about in here? So we'll have a wide-ranging presentation, but we'll be fast and furious as we get through it. So the primary learning objectives today is, again, to kind of think about what is happening with burnout? Why is it being talked about so much? Why is it important for us to chat about? How does it really impact us? And what are some of the origins? And what can we do about it? The main takeaway from today is going to be that burnout, as much as we want to talk about fostering individual resilience, as much as we want to talk about wellness initiatives, burnout is really a structural problem. And the more we try and address it at an individual level, sometimes the more we can exacerbate burnout. So we'll talk about that. We'll talk a little bit about the factors that influence the onset of burnout. And then a personal passion of mine, so I do some research on help seeking within the medical profession, is what are the barriers when folks are experiencing distress, when they might be going through difficulties, to actually reaching out and getting support. And because the barriers are so real and so prevalent, it's much more likely that you all will speak to a colleague rather than going to speak with somebody like myself as a psychologist or a mental health professional. So in many ways, you're on the front lines with one another. And you all know what the others within your local world are going through. You can speak more to the realities of what they're experiencing. So having a little bit of comfort with talking about suicide, knowing that mentioning the word suicide does not increase somebody's risk of completing suicide, and how to just chat about it more openly is really, really important. And that's a huge list of things, so let's jump in. So I work with, 4 days out of the week, I work at Des Moines University. 1 day out of the week, I'm here at the Cancer Resource Center. I wish I could do more, and actually I feel like I need to be doing more. There's so much need. But 4 days out of the week, I work with medical students who are very early on. In their first semester, I have them complete a burnout survey, very similar to what you'll be doing today. And within that first few months, the students are already reporting about 49%. Almost half the group is feeling burnt out. That's incredible within the first semester of medical school. And that's really impressive because there's nothing unique about physicians when they're starting off. It's not as though we're selecting some subset of the population that has a higher base rate of mental health concerns initially. Actually, they have lower likelihood of having personality disorders, which is a good news for physicians. It's not as though we're selecting some bizarre group of people to enter into nursing school, to enter into medical school, right? In fact, there's no difference. But within a first semester of medical school, at a little old osteopathic medical school here in Des Moines, Iowa, students are already experiencing high levels of burnout. And it's not just unique to medical students. It's true in the nursing profession as well, and a lot of allied health professionals. Rates are approximately equal. Why we take it so seriously at Des Moines University is that not only is it your individual suffering as a student, but it also translates to some negative academic factors. We have an integrity committee at Des Moines University and that deals with dishonesty and cheating. And students who are burnt out are actually much more likely to engage in unprofessional behaviors. So they might, in a large lecture auditorium like this, they might report that their friend is present when they actually didn't show up to a required lecture, those sorts of things. They're also much less likely to hold altruistic views of healthcare. And again, physicians are no different, nurses are no different than the general population, generally fairly altruistic, benevolent people who hold positive views of others, but that tends to decrease even within this first semester. And the reason we take that seriously early on in their medical careers is because, although it seems very small, maybe, to report that a friend is not present in the auditorium when they actually, report that they are present when they actually aren't, is that later down the line it can lead to more unprofessional conduct. So for example, saying that a lab test was ordered when in fact you forgot to, or admitted it from the patient encounter. So some of these things that later down the line can have more serious consequences. It also leads to just having serious thoughts about leaving medical school, of leaving the profession entirely, which at the physician or at the healthcare provider level is extremely expensive to institutions to go through the process of hiring a new professional. That in and of itself costs hundreds of thousands of dollars, depending. All right? And so it's no surprise that after this first semester of being initiated into the profession, that burnout continues on into one's medical career. So somewhere between 30 and 70% of physicians and nurses are experiencing burnout at any given time. The odds ratio is about 1.36, so about 36% more likely than the general population. It's associated with greater job turnover, absenteeism, lower morale, poorer quality care, and then a range of mental health conditions. And on the left-hand side, you'll see sort of what we'll be moving into here, which is that rates of burnout really vary pretty drastically by the specialty that one chooses. So when I'm providing some advising to medical students who are thinking about which specialty, sometimes they are interested in this data to think about for themselves, their own quality of life. On the very sort of lowest levels of burnout are in preventative medicine, dermatology, rates are still high, around 30 to 35%, all the way up to emergency medicine where rates are closer to 70%. So just by thinking about the fact that burnout varies drastically by the environment that somebody's finding themselves in, points to the idea that burnout is largely an environmental phenomenon, which we'll talk about. All right, so let's give you a very general definition of burnout, and then we're going to try to engage meaningfully in it here as a group. So burnout goes way back to the late 1970s. It's not a new phenomenon. It was originally developed within the helping professions, within counselors and psychologists, but then realized quickly that anyone providing care to another human being is likely to experience burnout. It has 3 primary factors, and this is from the Maslach Burnout Inventory, which is the biggest, sort of most commonly used inventory of burnout. The first is emotional exhaustion, so feeling that you cannot give of yourself emotionally. So basically feeling totally depleted in terms of our emotional reserves, not having much energy left over for others, which then sometimes leads to depersonalization or tending to objectify, dehumanize the person in front of us, in this case, the patient. So just to cope with our own lack of emotional reserve, we tend to hold less altruistic views of our patients, right? We tend to see them as maybe more deserving of their problems, seeing them as lazy or seeing them as having poor behaviors, whatever it might be. And that helps us to protect ourselves in the encounter with the patient when we have just very little left to give. And when those two things, and typically burnout is thought about as high levels in both of those, go on for long enough, it tends to lead to reduced personal accomplishment. Feeling like we're not successful healthcare providers, or feeling like we're not successful students, feeling like we have very little accomplishment in our work lives. So, hopefully you've got a clicker available to you. And as a psychologist, I'm very interested in assessment. psychometrics. So I'd like you to take a moment here. There's 3 questions related to burnout. And Maslow would say, actually, I wasn't supposed to tell you that this was a burnout inventory because it would skew your results, but too late. I've already kind of mentioned that. But here are the questions. Please read each statement carefully and decide if you ever feel this way about your job. If you've never had this feeling, select never. If you've had this feeling before, indicate how often you feel by selecting the phrase that best describes how frequently you feel that way. So this will be reported in aggregate. I don't know what each of you individually responds with. So if your supervisor is here, you don't have to worry about repercussions. So do try to be honest. And also don't feel like you have to make up burnout when it doesn't exist. I want this to be valid data or representative of what folks in this room are experiencing. So first question is, first statement is, I feel emotionally drained from my work. All the way from every day to never. And maybe Tim can help me out. Is everybody able to respond, or do I need to click anything here? This is my first experience with Turning Point. Ah, nice. Okay. Wow. Great work. Oh, interesting. Wow. So we have sort of a bimodal distribution going on here. From those folks who are feeling fairly at the high level a few times a week to maybe folks who are feeling lower. Now, you have just absolutely mimicked national prevalence rates. So anything above a few times a week, so this is the emotional exhaustion domain, tends to be considered burnout. So about 30% of the folks in this room are feeling burned out. Anybody surprised by that? I'm not, luckily. It turned out that you happened to just confirm exactly what we would expect. But still, even those folks who are not feeling it a few times a week, to feel emotionally drained once a week or a few times a month is considerable. All right, so I'm going to keep note of that. Let's move on to the next one. I've accomplished many worthwhile things in this job. The feeling, do you have that feeling every day? Never, etc. The responses are ticking in. Oh, okay. So we have 61 folks responding here. So actually, rates of personal accomplishment, and sometimes what Maslow did was tended not to use this scale, tended to use the emotional exhaustion and the depersonalization one. This sort of personal level of personal accomplishment is what tends to happen when burnout goes on for extended periods. When we felt burnout long enough, and 2/3 of folks who experience burnout don't necessarily see a resolution of that burnout, we tend to also experience reduced personal accomplishment. So this is sort of the more extreme end. So only about 4%, so what they would have the cutoff is once a month or less. So only about 4% of folks here are feeling reduced personal accomplishment. So that's good news. But still, to feel that you're not, to feel like you're not having that happen very often, 18% say only a few times a month. So worth being aware of. So that's good news. That's more reassuring news. Here's the last one. I don't really care what happens to some patients. Now be honest, if this is happening. This one might be a little bit more extreme on the depersonalization scale, but does this happen once a week? All right. Okay, so this is actually really reassuring. So Mary Greeley Medical Center is doing a phenomenal job of maintaining personalization. So we're actually really good here in terms of feeling on track with not feeling depersonalized or not objectifying our patients. So what they would tend to say is once a week or more often would be sort of a sign of burnout, of depersonalization. So actually we're doing something right here as a center, so maybe we need to talk about that and celebrate that success. But actually, and depending on the survey that they would use, some folks would use high on just emotional exhaustion, some folks will use high on both depersonalization and emotional exhaustion. Still, we're seeing emotionally exhausted folks at Mary Greeley, about 30% of the time. But we're maintaining a good emphasis on patient care. So that's good news. So only about 7%, right, are having levels of depersonalization. For those 7% of you in this room, I just want to normalize that, okay? This isn't a personal failing of you, right? That this is oftentimes, again, burnout is a workplace-related phenomenon. It's a structural problem, not necessarily a personal one. So, given the data here, and we just talked about these, what are the primary drivers of burnout? So Colin West is a researcher. He actually had a really great meta-analysis in the last year about burnout interventions. Colin West says physicians who work too much and too inefficiently with too little control and sense of purpose end up flaming out more so than do doctors who have fewer hours with fewer obstacles, all the while feeling satisfied with their autonomy and value. And that is actually a very accurate description of the causes of burnout. So the biggest one is time demands and uncertainty about the future. So we can develop experimental neuroses in dogs by letting them not be able to predict when a shock is going to happen. So sort of very similarly as physicians, we much prefer to know when a patient is going to be scheduled. We much prefer to have some sense of control over that, because then our fear response, our anxiety response can be elevated and then quickly dissipate appropriately, just with like any stressor. However, when those stressors are unpredictable, there's no way for us to know when they're going to happen. We tend to have a high base level of hyperarousal, hypervigilance, and sort of that can lead to burnout, of course. Lack of control, inherently difficult job situations, interpersonal conflicts, and ultimately feeling one's personal needs are inconsequential. So what I want to drive home here again is for that 7% who are really feeling depersonalized, but for the 30% who are having some emotional exhaustion, is that very few demographic factors, very few personality factors reliably predict burnout. Instead, it's much more about these perceived environmental factors. Gender, age, all of these sorts of things don't necessarily predict burnout. And neuroticism and extroversion, part of the big five of personality, have only a weak correlation with levels of burnout. So it's perhaps not surprising then that the most effective interventions are structural in nature. Things about talking about practice delivery changes, things about limiting the duty hour requirements, as opposed to individual interventions, facilitated small group, stress management, mindfulness-based approaches. When I talk about wellness to the students at DMU, I'm very much a proponent of mindfulness. I love mindfulness training and mindfulness-based stress reduction. When I tell the students, like, hey, I really want to implement a mindfulness-based stress reduction program, we'll have you meet once a week for the next 8 weeks to talk about reducing your stress. And they say, what would help me much more is if you didn't do that. I would much prefer to just have an hour of free time. And I say to them, you're absolutely right. Ultimately, adding more to individual programming tends to undermine autonomy, which is a basic psychological need. And it also tends to undermine the reality of what causes burnout, which is not some individual lack of resilience. This isn't to say that these individual-based interventions are not important or helpful, and we'll talk about them, but it's just to say that structural interventions tend to be much more effective. So, addressing burnout involves mitigating the environmental drivers and, of course, bolstering individual resiliency. The main thing is that to address burnout, we want to engage. Workplace engagement, again, is the opposite of burnout. Just like you can't be anxious and relaxed at the same time, which we utilize in counter conditioning for treatment of certain conditions, you can't be burnt out and engaged at the same time. So what we really want to be doing is involving providers in not only the healthcare provision, but also the management of healthcare, moving away from sort of providers as carpenters and more to providers as architects, right, who are helping to design and implement the care that's being provided. So let's talk about this. So this is, again, engagement, right, is the antidote. So let's talk about what's happening in your own local world. This doesn't necessarily need to be a high-level discussion. This needs to be about what you're actually experiencing as individuals. So what I'm going to do is just I'm going to orient you all to your own basic psychological needs, whether or not you're acknowledging them in this moment. I'm going to point to them. And then what I want you to do is talk about how much you felt each of these 3 things this morning. Let's assuming that you went to work this morning, you're here right now, and that this morning is sort of a representative of a typical day for you. How much did you feel related? So feeling connected to others, feeling respected, feeling understood. And this is not my work. This is from Deci and Ryan, so they talk about self-determination theory. This is pretty well supported in terms of your basic needs. How much did you feel autonomous, having control over your actions, over your schedule, having free will? And having competence. How often did you feel effective? How did you feel like the challenges were optimal for your capacity, right? So just again, this is not about, I hear so much about work-life balance, but it's much more about work-life integration. We don't go to work and somehow no longer have psychological needs, right? We don't want to compartmentalize work and life. In fact, we find that systems are much more effective, providers able to give better care when these basic psychological needs are being met. We're intrinsically motivated to go to work. We're intrinsically motivated to provide patient care. So, with the people next to you, as much as you're willing, as much as you feel talkative right now, consider the typical day, if this morning was a typical day. When did you feel most related, autonomous, competent? When did you feel least related, autonomous, and competent? Okay, so I'll just give you a few minutes here. Hopefully the people next to you work with. If not, that's okay. You can still talk about this topic. So this is going contrary to your training, probably, which suggests you shouldn't complain or you shouldn't ventilate about your concerns. But again, we're moving away from carpentry to architecture. All right. So maybe just for the sake of time, we can bring it to the larger group. I'm very curious. What maybe were some common threats and supports to your basic needs? When did you, if somebody's willing to share in the larger group, what was maybe a threat to your relatedness, your competence, or your autonomy? What's been a support? Anybody willing to engage with me? Yes, thank you, Dr. Yes. No, absolutely. Yeah. Mm-hmm. Right. Yeah. So being on call is a huge drain, right? So just acknowledging the realities of that situation in terms of competence, autonomy, and relatedness. You're often alone. You're going through this experience alone. It's unpredictable. It's creating some helplessness here. Just creating baseline physiological arousal that with no resolution. Yeah, of course it would undermine these things. So as a system, maybe being aware of the reality of the toll of that on any one physician and wanting to, of course, systems oftentimes try and manage rotating call schedules, that sort of thing, but just being intentional about that. Yeah. Yeah. Ah. Mm-hmm. Yes. Mm. Mm-hmm. Yeah. Yes. So you've been sort of noting the narrative here of just sort of increasing decrements in autonomy. You're giving up control in order to have greater competence, right? To sacrifice that. But at some point you recognize, man, I have no autonomy, right? And so I need to kind of there needs to be some system in place to catch that, to when that happens, and I've experienced that myself in my own practice, when that's starting to happen, to then engage in a conversation about that as a driver of burnout. And that process of having you engaged and saying, hey, I'm aware of autonomy is not, or my autonomy is not being met here, that I can have some outlet for talking about it, right? So basically, this is just to say, and this is sort of the Mayo Clinic model, and it doesn't come from Mayo Clinic. It's been around, since the 1980s, that you need to be engaging providers in the process of improving care. But there needs to be that feedback mechanism, that loop of listening to or to identify and understand what is driving burnout in the local world, as opposed to those broad things that we were talking about are generalities. We need to know what's happening in the local world. Then empowering providers to develop and implement solutions. So it sounds like we come up with our own individual solutions, but we need to feel empowered to do that and to be an architect in the provision of care. And then developing maybe, we might identify you as a leader, right? As somebody who's willing to sort of help to talk about burnout openly. So this is just one model, right? But a similar sort of mechanism of engaging providers in that process of providing feedback and helping to manage burnout is actually the biggest reduction. Just talking about it and here has been shown to reduce burnout a little bit, but to really address it, it needs to be not like an individual wellness program, but rather this sort of cyclical mechanism, right? So it needs to be structural. So what I want to talk about kind of in the remainder of the time I have today is when burnout goes on for too long, if we've been experiencing it. And again, it doesn't seem like only 7% of the folks here were experiencing depersonalization, but it's still a very real phenomenon. What happens when burnout has been going on long enough and we start to experience distress as a provider? And why is it so hard for a provider to seek help? And this is sort of my research area, what I'm really interested in. Well, basically just going back to the Diathesis-Stress Model, when it comes to distress, a little stress is good. Eustress, an important phenomenon, helps us to motivate to perform at our best. But when it becomes overwhelming, is when, or it overwhelms our individual capacities to cope, that's when it becomes distress and can lead to more significant concerns. Basically, the Diathesis-Stress Model is just to say, no matter how resilient you are as an individual, if you're experiencing enough stress, it's going to overwhelm you, and at some point, you're going to develop distress and have disorder or difficulties. Distress is when it gets to that point of feeling irritable, feeling anxious, feeling things are worthless, feeling depressed, when it starts to get to that level of anxiety or mood disorders. The difficulty with talking about providers is that we're often unwilling to seek help for our own distress. We're often unwilling for various reasons. We're often willing to do it for ourselves. But even if that's the case, perhaps you can be motivated by the fact that it's impacting your patients when you're distressed, right? It leads to greater medical errors, riskier prescribing profiles, reduced empathy, as we've talked about, reduced patient satisfaction, lower patient compliance, unfortunately more litigation, which is in itself a driver of distress, and then it's costly to the medical profession. If you leave specialties or change practices, and if you leave patient care entirely, it's extremely expensive, right? So it's for these reasons that actually now folks are starting to talk about physician or provider wellness as the missing quality indicator, right? It needs to be something that we're actively talking about as an indicator of how the quality of care that we're able to provide as an institution. So again, we tend to do it for our patients, not for ourselves. So this is just a brief survey. It was a fairly small sample size, a little less than 100 respondents of folks who are currently in residency. And they were asked, please indicate whether you would or would not seek support for the following difficulties. And we see here the most likely that folks were to seek support for were legal situations or being involved in a medical error, right? So things that affect patient cares. Much less likely if they're experiencing a mental illness in a family member, personal life struggles, physical illness in a family member, mental illness in a self, or burnout, right? We're just much less likely to do things for ourselves as providers. The most often cited is just a lack of time. We're worried about evaluations, we're worried about how it might impact patient care. Also is a lack of confidentiality, fears of negative impact on one's career, and the stigma of mental health care, right? So And the reason that this is not some absurdity that physicians are worried about the stigma of getting treatment, right? There's actually this really, really interesting study done by folks at Mayo about medical licensure applications asking about mental illness versus asking about impairment. So if you ask about, the ideal would be to ask, do you currently have a mental health concern, substance use concern, or other physical condition that is impairing your ability to perform your duties? But instead, what is being asked most of the time is, do you currently have a mental health condition, right? And the concern about that is that a lot of state boards, about a third of the boards that were surveyed, said that they would actually sanction a physician just for having a mental health diagnosis. If you go to see a psychologist, you go to see a mental health professional, they're likely to give you a mental health diagnosis because that's how they conceptualize their treatment of you. That's also how they get reimbursed for medical services. Just by having a medical condition, physicians are going to be in front of their medical board, right? Or for having a mental health condition, they're going to be in front of the medical board. And it's, it varies across state to state, but Iowa is one where we don't ask about mental health concern on the initial licensure application, but then we ask about it on the renewal application. You have to reveal if you've had a mental health condition rather than if you have a mental health condition that's impairing your ability to provide services, right? So it's no surprise that stigma exists in the medical professions. But even just our values as providers, as healthcare, being resilient, being stoic, being not the patient but the provider, having values of sort of self-enhancement, those sorts of things can interfere with our desire to seek treatment. Because if you seek help, that suggests something about you and your personal weakness, This slide is just basically to say that there's a lot of things that go into predicting whether or not an individual will seek help. And this is sort of what I'm interested in studying within medical students at Des Moines University right now, all the various barriers to help seeking. It's a complex process. And so you're much more likely to rely on your peers. So when surveyed, residents were much more likely to talk with a colleague, faculty or resident, or a program director or a chief resident or a faculty peer support, much less likely to talk to a mental health professional, right? Or a clergy member or somebody outside. So that's what the rest of today will be focused on. How do you recognize and respond to distress and the prevalence of suicidality that exists? So again, suicidality, suicidal ideation is about twice as prevalent for physicians as it is in the general population. That's because there's the general risk factors that affect all people. Sometimes the acronym SAD persons is used. Being male, being greater than 60 years of age, having depression, previous attempts. Substance use is a huge one. Having had a suicide in one's family. In some ways, it kind of gives permission to the act of suicide for oneself. Not having support, being ill, is combined with the possibility of lawsuits and medical license investigations. When a medical license investigation happens, the risk of suicide increases dramatically. Professional isolation that exists, if you're having to follow your profession, that sometimes separates you from your natural support systems, and just having intense workplace demands and the sort of inherent nature of the position. All those things lead to increased risk. So what to look out for if a colleague might be experiencing distress? Generally it's deteriorating personal hygiene, maybe it's not showing up to professional duties, rapid change. You're seeing a lot of changes in someone's emotional range. They appear sleep deprived. There's greater professional errors. A lot of times what you'll see is folks stopping to show up or citing unexplained personal problems when they're having decreased performance or not attending meetings, increased substance use, or sometimes visiting website. It can be as overt as visiting websites related to suicide or talking or writing more frequently about death, but oftentimes it's much more hidden than that. So if you suspect that a colleague might be struggling, the biggest thing to do is just to normalize it. A lot of folks struggle with these feelings, have thoughts of hurting themselves. Is that something you're experiencing? It seems like you've been really down lately. I'm concerned about you. Are you having any thoughts of suicide? The biggest barrier to assessing is an unwillingness to say the word suicide, or fears about what that might do, or worried that saying suicide might increase somebody's risk. But that's absolutely the opposite of the reality, right? If somebody has been having these thoughts, saying the word suicide is not going to suddenly make them act on them, or it's not going to put the idea into somebody's head. In fact, the opposite will happen. It gives them space to talk about it and potentially get support for that. But what do you do if the answer is yes? What if somebody says, yeah, you know what, actually I have been having thoughts about hurting myself? First of all, you can help to reframe those suicidal thoughts as an important sign. So this is cognitive reframing that we as psychologists do all the time. So I'm really glad that you told me. Suicidal thoughts are something for us to take very seriously. It sounds like it's a sign that things are just really feeling hopeless right now, that you really need something to change, that you really need support, right? So it's usually a sign, we usually think of it as a symptom of an underlying problem, right? That this suicidal thought is sort of the symptom of real hopelessness. Maybe you are really burnt out. Maybe the work demands are kind of really overwhelming your ability to cope right now. Maybe there's things going on at home. So it's sort of like a cognitive reframing of what suicidal thoughts mean. These thoughts are really important. They're telling us that things have gotten really bad and we need to get some help. And then just sort of gently asking if they thought about talking to somebody. Being confident that seeking help will improve their symptoms. So I've sort of given this information already, but psychotherapy, its effectiveness rivals some of the most effective medical treatments. It has a very high effect size. Therapy is effective, has pretty minimal side effect profile. So you can know that getting help will be useful for most folks who seek treatment. And then just reframe the willingness to seek help as a strength. So again, a lot of times the values of self-enhancement, self-reliance, stoicism that we sort of ensconce as a profession can undermine one's willingness to seek help because it sort of suggests that to do so would be a failure, a personal weakness. So saying that, actually the strongest thing you can do is to reach out, to talk to somebody, is really helpful in those times. And the final thing is if you're really worried about somebody, don't hold your concern alone. So again, ideation itself doesn't mean that somebody's actively suicidal. About a third of those who with suicidal ideation do attempt to suicide, but obviously it's dramatically increasing somebody's risk. So I did speak with some of the providers here at the emergency department. They're well versed even with having folks who are current providers be seen at the emergency department for behavioral health concerns. They have some experience navigating the complexity of confidentiality in that area. So they can, just walking them even down to the emergency department here. But there's also some really great local and national lines. So I've called both of these. The Crisis Observation Center in Des Moines is a really great service. And the national hotline actually even takes you within 2 minutes they redirect you to a provider in Cedar Rapids. So it's not super local, but you will speak to a real person right away, right? So these things are really important if you're worried about someone who might be suicidal or a colleague, or if somebody has admitted to feeling suicidal and you're worried about their safety, right? So now the really difficult part of this presentation. We're going to actually try it out. So it's easy to talk about it, but it's actually hard to do it. So what I'm going to have us do is we're going to find somebody in your near vicinity, and we're going to do a little bit of a role play. And the reason I push us to do this is because I've talked about this with medical students, and then when it comes time to actually try it out, they feel very uncomfortable, and they're surprised at how of a bad job they did. So, right? So we're going to actually try it out together and just see how hard it is as a group. Okay? So with somebody next to you, determine who's going to go first and be sort of the assessor, right? And who's going to sort of role play the distressed colleague. If you're willing, I won't mandate anything. And if you just kind of want to watch as well, that's totally fine. We'll brainstorm it out as a group. And I have until 1, is that right? Or am I off on time? I think I have 10 minutes remaining. Okay. So once you've decided who's going to assess first, I'll have the assessor and the patient, the colleague rather, not the patient. You're both welcome to read sort of the subjective and the objective situation of this particular case. So this is sort of the subjective and objective information you have about your colleague. They have depressed mood, they're anxious, reporting insomnia, having some weight loss. These symptoms have been present for about 1 week. They might have been present earlier, but they seem to have really gotten worse in the past week. And that patient is talking to you, their colleague, about how they're feeling. You have gone out with that colleague. When you drag them outside, they will walk with you, but otherwise they're not getting much exercise. The colleague is managing to go to work and see patients. They took one day off recently because they weren't feeling themselves. They really don't want to do counseling. They're kind of hesitant to do medications. You haven't really talked about suicide with this person. Objectively, weight loss is noted, mood is quiet, anxiety is present, but no delusions or hallucinations. Still showing insights, adequate train of thought. Basic labs are normal, right? So we're almost doing a soap note here for your colleague. All right, so all of the folks who are going to be the assessor, go ahead and close your eyes. You're not going to watch the next slide. All of the colleagues, the distressed colleague, you're the one who's going to read this next slide, okay? So this is your background. So we'll give you just a couple of minutes to identify who you are and what you've been experiencing. And keep in mind, again, suicidal ideation in the general population is around 6%. In physicians and other health professionals, it's closer to 11.2%, so 1 in 10. So it's a serious issue. All right, any more of the colleagues need a little bit more time to read? Okay, as you're ready, begin your dialogue. So I'll go back a couple slides for the assessor to know what to do here. All right. Feel free to slowly come back here to the group. And I'm just curious, kind of a final discussion. Were there things that made this easy or hard to ask? Any fears? What it was like to be on the receiving end? Did you feel like you wanted maybe an intervention you tried that worked really well? Anybody willing to share how difficult or easy it was? Yeah. Sure. Yeah. Really, the awkwardness of saying the word suicide and like worried that you're pathologizing them or something like that, maybe. Saying there's something wrong with you for having these thoughts. Yeah. Yeah. Absolutely, yeah. Yep. So oftentimes what I found most helpful is normalizing it, not as much for the person who's being assessed, but for the assessor. These thoughts are actually really common. A lot of folks who are in your condition or in your experience are thinking about suicide. And that also gives us permission to say, okay, I'm not telling you you're crazy, or something like that. I'm just sort of assessing a normal human thing. Other things that folks noticed or made it easy or difficult? Thank you for trying it, by the way. This is not a hot, real great, fun, uplifting topic, but any other reactions or just things you'd like to share? Or concerns about this? Yeah. Yeah. Yes, the Kleenex move. Yeah, like here's the Kleenex. Actually, we talk a lot about Kleenex are like the trait our economy as psychologists, and we talk a lot about how to use Kleenexes. I actually don't like to use. I like to have them present in the room, but I very rarely offer somebody a Kleenex because my sense is that tears are very normative and a human reaction to distressing situations. So if the person wants to clean themselves up, that's totally fine. But I typically don't encourage somebody to do so. Yeah. Yeah. Yes, yeah, yeah. Mm. Yeah. on the provider side. So a couple questions about the electronic health record and its relationship to burnout, depersonalization. And I personally haven't studied that, but it's very clear, that the burnout continues to rise, and it's mostly attributable to these administrative tasks that are decreasing autonomy, control over one's schedule, increasing workplace demands, et cetera. So yeah, it's a pretty clear link between EHR and burnout, and then depersonalization on the extreme end. In terms of screening, I really like that idea. So build in a screener into Epic. You have to log in every other week or something and say, this is how I'm doing, and we sort of track that and we talk about it openly as a group. I love that idea. I will support that initiative 100% if we choose to implement it. But I think I haven't heard of that idea actually, but I think it's a great one. Because we're doing the PHQ-9 all the time for patients with PHQ-3, but not for much for ourselves. So thank you again for engaging in that. Basically, I want to kind of drive home the main points of today, which is burnout and distress are prevalent. Causes are largely structural. Independent individual interventions can be useful, but mostly it's this process of engaging providers in giving feedback and being able to make changes into their own workplace, local worlds. Many barriers make it likely for healthcare professionals to rely on peers. We talked about time demands, stigma, values, worries about effects on professional advancement, et cetera. So it's much more likely that you're going to talk with a colleague. So to respond to a suicidal peer, absolutely talk freely about suicidal thoughts, take them seriously, know that there's resources available, reframe the decision to seek help as a strength rather than a weakness. And don't ever hold your concern alone. Great. Well, it seems like there might be a couple of, or no, maybe there are questions, maybe not, but that concludes kind of my main take-homes. Here's the references. There's more references I could cite because the literature just continues to grow, unfortunately. So happy to answer if there are any kind of lingering thoughts, reactions. Yeah. Yeah.
Payment and delivery of healthcare in the United States.
Mm-hmm.
And at the same time, we've seen burnout levels rise dramatically since the beginning of the ACA in 2008.
Sure. Yeah.
How much has it been studied? Is there a causal link? Is there a relationship?
Mm-hmm.
What are your thoughts? And
yeah, that's a good question.
Other thoughts.
So question just about the Affordable Care Act and its impact sort of on provider burnout. And I think there's certainly a correlational link, right? We see greater increases in burnout, especially over the past decade. And anything that's going to undermine those basic psychological needs, so we can point to those various ways that the ACA might be doing that, or just more administrative burden is just a recipe for burnout, right? I don't know specifically if there's been studied a link between the two, but definitely would be curious about that, kind of just as a more systemic level, right? And I think the main take home again is that it is these structural things that contribute to burnout. It's not it's not like physicians now are weaker, or this generation of this upcoming group of healthcare providers is, rascals, and they're just not strong enough, right? It's just not the case. Yeah. Other questions or? Great. Well, thanks again for your time this afternoon.